So, considering no questions from the previous session, so we will start with today's session. Um, so in last session, we learned as to how we are going to present the important identified risk basically, right? So hope everybody is clear with that as to since it's an important identified risk. So we have the causality established for that event and we are not focusing on causality. We just focus as to what is the if the severity is increased as from the means whatever is mentioned in RSI, if the severity is getting increased, like we discuss about fatal and life threatening, or if the frequency of the events are getting increased, as we discussed just now, based on the frequency provided in RSI. And if we have fatal cases, suppose whether it is mentioned in RSI or not. So if we have fatal cases, then we have to present a different analysis for those fatal cases. Like suppose if it is mentioned in RSI, then we present what is the cumulative uh, what is the cumulative analysis of the fatal cases received during this reporting interval, and we will mention the RSI statement that RSI says that it is already a fatal, it is associated with fatal outcome. Whatever statement is mentioned in RSI, we will mention that and provide our company causality. There is no change in the and or no new information regarding this. So this is how we present important identified risk. Now today we will come to important potential risk. How do we present the important potential risk? So in last session also I told you guys that there is nothing much difference from the important identified and important potential. Important identified by important identified I means nothing much difference. So how you are presenting the fatal cases which are not in RSI. Your RSI doesn't say that it is fatal and now you are assessing the causality for the fatal cases or the life-threatening cases. So in the same manner we provide the analysis for important potential risk. Why? Because important potential risk is doesn't have a causality, established causality. So when we are monitoring this important potential risk in our P-burs, so ideally we are trying to find the causality. If we are able to get the causality for those events, if the causality is getting confirmed for those events when we are doing the aggregate analysis. So that's why we monitor those important potential risks in aggregate. So now what will happen? You will get a line listing. So same, we will consider hypersensitivity. Let me present the screen. You are able to see my screen?
Yes.
Okay. Sure. We'll open the same line listing hypersensitivity one. So now suppose hypersensitivity is your important potential risk. And you got these 10 cases for important potential risk during your reporting interval. Now you have to analyze these cases. So first paragraph, as I told you, for important identified risk, like what is the type of report, how many means what, how many are initial, how many are follow up. If follow up, then in follow up, is it something mentioned about your drug and your event hypersensitivity? Then only you will include, otherwise you can exclude those. Then what would be the reporter type, whether it is a medically confirmed or non-medically confirmed? What is the report type, whether it is from a spontaneous source, whether it is from literature, whether it is from PMS, how is it? Then what would be the demographic distribution, means how many male, how many female, how many you don't know the gender. Then in male, how many, what are the age, means like suppose if it is mentioned that there are 5 males and one is having an age of 18 years, one is having an age of 65 years. So you can write that 5 males in the age range from 18 years to 65 years. Some companies say that give a median age. So suppose five are there, so you will add and divide by five. It will give a median age. So you can give a median age also, that this is the median age of the patients that have experienced this hypersensitivity. So this is how you give the first paragraph as to giving a gist that how many cases were there, how many initial follow-up, as we discussed. Okay. Now, when you will move to analyze these cases, so before giving the analysis, means a cumulative analysis or a discussion point, you will also present the number of PTs as we do in identified risk. So you will present the number of PTs. Like here you can see hypersensitivity is there, skin allergy is there, then rash is there, dermatitis is there. So you will give you pruritus allergic is there. So you will give a distribution of the PTs. You will put a pivot here. You guys would be aware with the Excel tricks like pivot, filtering, and everything, I believe, right? Am I correct?
Yes, sir. Pivot table.
Pivot table, you are aware?
We used to do it with some.
These are the basic tricks you can learn. If you don't, if someone is not aware who is not speaking here, so don't worry, you can see on YouTube and everything, but I'll show you for one. See, if you go to insert, there is a pivot table. See, you can see here is a pivot table. So from table range, it will ask. So you can select this and then they will ask for table range. So they have taken A1 to Y10. So it is fine, I think. Only one he is taking. Y10. Y10 only. So it has covered mostly. So you can put a new worksheet, make it okay. You will get a table here, right? Like I was asking, we have to present the number of PTs. So what was the column for number of PTs? Do you remember what was the preferred term? This one, right?
Yes, sir.
People, this was the preferred term. So you can
Yes.
bring it to rows. Okay. Now, can you see here? The preferred terms are there. Dermatitis, hypersensitivity, pruritus allergic, rash, skin allergy. Can you see? Yes or no?
Yes.
Yes, yes.
Okay. So what is the count for these case PTs? So you can put it in values. So you will get the count. Now, can you see here count? So since it is staggered, so you can sort and filter. Okay. Click on the first, sort and filter. So see here, you can see sort and filter in the home page, sort largest to smallest. Do it. It will give you. Now you have the same table. You have to paste it there. See, you can see hypersensitivity 5 cases, skin allergy 1, rash 1, dermatitis 1, pruritus allergic 1. Total 9. Was the same count there? Let's come to the data. Is the same count here? Can you see? People, those who are not aware about pivot.
Yes, sir.
So this is how we put the pivot. So this is how we differentiate the data in the Excel sheet. Okay. So you will practice it on your Excel or whatever Excel you are getting in your companies also. On that also you can practice the pivot. You can see the YouTube videos for pivot. So you will learn more about those pivots. So don't worry. It is a simple task Excel for aggregate reporting. So this is how you bifurcated the PTs. Like, so there were 5 PTs of hypersensitivity. So this table you will present in after that paragraph of how many cases bifurcation. The same way you can have a bifurcation cases also, like HCP and everything. You will put a filter and you will get a bifurcation. So don't worry about that. You will learn all those things. Okay. So this is how you will present the data which is there in Excel in your report. Now you will come to analysis. So I have to do my analysis also. So when you will go here, you can make your own columns. Like see, here I have made case bucketing or analysis, and I have given comments also when we were doing signal at that time. So case bucketing, if you are doing, then you can, when you are analyzing, like for signal, it was category A, category B, category C. But in this potential case, this important potential risk, when you are analyzing the case, you have to focus on those 6 to 7 pointers that you do for causality assessment, right? Like if the TTO is provided, then what is the TTO? So in bucketing, you will mention separate sections. Like you can mention here TTO, then you can give here de-challenge, re-challenge, then you can write confounding factors, means medical history, concomitant, put every, in starting when you are doing aggregate, put each column for everything. Like I mentioned, I should write also TTO, okay? Then you can put here, uh, after TTO we see for medical history. Confounder, if you put, then you can write both concomitant and medical history, but initially I'll suggest that put it separate everything. Concomitant. They have given here, but in this section, what you will write the relevant only, not everything. Because if you see concomitant medications here, they have given concomitant medications here, but they have given everything here. So you don't have to write everything. What you will write in this section, medical history and concomitant, like suppose hypersensitivity is there. So if he has any hypersensitivity related some medical history, or if he is having some concomitant medication that is causing, that could cause the hypersensitivity as per their RSI. Concomitant, then you can write de-challenge, then you can write re-challenge, then you can write lab test, relevant lab test, okay? Relevant lab test, right? So these are the main parameters that you will. So now what will happen? Suppose if you have these things in place. So TTO, you can write it here also, or you can take from here because they have provided in this listing, but in some listing it is not provided as different. TTO is not provided as a different column. It is in the narrative that you have to search. So from narrative, if you read, you will have to read and point out as to how, what was the TTO for that reaction. So you will put it here 7 days. Okay. So why we bifurcate into these columns? So that we can put the pivot or the filter and write the data into the report. Like suppose if these 9 cases have TTO, so see, can you see here? They have provided the TTO here. So TTO is ranging from 10 hours to, or 3 hours to 10 days, 16 days, right? Can you see from here? Can you see people?
Yes.
What is the range of TTO? 3 hours to 16 days, right? So when you have put into this column, like the way you will put, the same has been put here. So when you have the all the data in concrete here, then you can present the data that TTO was ranging from 3 hours to 16 days. So hypersensitivity reactions after the treatment for 16 days, it's quite unlikely to happen, but you can see your RSI, what your RSI states, and what is the available information on that. Based on that, you can write. So this is how you will present that in among the 9 cases, the TTO was ranging from 3 hours to 16 days. In the same way, medical history, when you will say, you will present the, you will write the relevant lab medical history here. Like suppose if the patient was like, see, he, in this case, the patient is allergic to beeswax. So allergic to beeswax will come, not the diabetes and hypertension. So you can write in this section allergics to beeswax. So here he is having a relevant history of seasonal allergy. You can write here seasonal allergy. So in the same manner, you will write that in 2 cases of the 9 case reports, in 2 cases, the patient was allergic to beeswax and he has seasonal allergy, or relevant medical history was reported allergic to beeswax and seasonal allergy. So in the remaining 7 cases, there was no confounder from medical history perspective. And now if you go to concomitant medication, so you will see what medication he was using. So you will go to the SMPC of that medicine to see that drug SMPC, to see whether this hypersensitivity, skin rash or allergic reactions are listed in its SMPC or not. If it is listed, then you will put it as confounder. Suppose amoxicillin is known to cause hypersensitivity, so you will put amoxicillin here as concomitant medication. So it is a confounder for you. It is your analysis that now amoxicillin is confounding my hypersensitivity reaction. In the same way, if dacarbazine is SMPC also says that the its SMPC says that hypersensitivity is known, so you will put dacarbazine here. And then you will write your analysis about concomitant medication that of the 9 case reports, 2 case reports reported amoxicillin and dacarbazine, whose in means the RSI of both the molecules consider hypersensitivity as a listed reaction. So these 2 case reports are out of the confound, means out due to confounding. 2 from medical history are out due to confounding. Okay. Then you will see whether there was D-challenge done. D-challenge means action taken with the drug. What was the action taken with the drug? So if suppose they have given here, D-challenge, they see they have given positive D-challenge in 4 cases. So you have to look into the narrative of these 4 cases as to what is the positive D-challenge, why they are saying positive D-challenge. So if the narrative is there, then you will go. Ideally, in every line listing, there would be narrative. They have just because of instead of narrative, they have provided all the columns. So that's why everything is in crystal clear here. So, but you have to look into the narrative why they are saying positive D challenge. Like suppose if hypersensitivity reaction happened, immediately the drug was withdrawn, and after withdrawing 1 or 2 days later, or maybe after withdrawing the drug also, the reaction started fading off. So this is a true D challenge. But if they say that the drug was withdrawn, but treatment was given, so that is not a true D challenge. So you can say that you cannot consider it as a true D challenge. So are you getting my point as to what I am saying? Correct? Till now it is clear? People, is it clear? Any doubt?
Very clear.
Okay. And rechallenge the same manner. If the drug was stopped and the reaction also stopped, then later on it was again started. The drug was again rechallenged or again started for the patient, but again the patient has the hypersensitivity reaction. So this is a more weightage. Means if the case is having a rechallenge positive, then it has more weightage. So it confirms it confirms that it is related to the drug, but it is not giving a causality, confirmed causality, but it is a more strength if it rechallenge is positive. Okay. So in the same manner, you will write what was the rechallenge results here. However, in these cases, there is no rechallenge given. Now relevant lab test. So in hypersensitivity, so we can say like suppose again, instead of hypersensitivity, if it is mentioned that the event is DRESS, then in DRESS, what could be the relevant lab test? So Regis-Car score. So if they have done Regis-Car score, what was the score for that? So that is a confirmatory test for DRESS. So if this kind of tests are reported in the case, then you can write that Regis-Car score as this 5, 6, 7, whatever is. So that is a relevant lab test. Everything is not relevant. Okay. So did you understand why do you make these columns and put the information here so that you can write into your report from these, not looking at all this, whatever is done here. Tell me guys, any doubt here till here?
So this is for potential risk, right?
Yeah.
And for in identified risk for fatal events also we will do
The same way you can do.
So,
See,
for this particular section 16, we'll be receiving raw data in the format of line listing itself. Is that correct?
right. In the
Okay.
line listing, it is in the format of Excel.
Okay. Okay.
See, whatever safety sections you are writing, okay, other than important identified, because in important identified, we don't focus on causality. That is the only section, okay. Other than that, if you are doing important potential risk, if you are doing missing information, if you are doing medication error cases, if you are doing off-label use cases, if you are giving a causality for the literatures being processed in section 11, everywhere, wherever you are giving the causality, the same pattern is followed. No change in the pattern. If you are doing signal evaluation report at that time also, you are following the same pattern because everywhere you are trying to search the causality because that is the factor which will decide whether it will become a important risk or not.
So
Any
this
questions?
causality assessment will be done by MR or
No,
we do it?
no. We will do it and MAR will confirm it. Okay. In ICSR,
Okay.
MR does, but here PV scientist will do, means you will do everything. You will present in the report, you will write in the report. MR has the responsibility to cross check and verify it. And if there is any comment, he will give the comment which you have to address. Okay. Any questions, people?
Oh.
No questions? Shall we move forward? So till now, from 16.3, you have learned as to how you are going to analyze important identified and important potential. Correct? Now we will move to missing information. Shall we move to
s- uh,
Yeah, yeah.
Amit, so you showed how to write the data. So okay, I have to bifurcate the data, line
Hmm,
listing data.
hmm,
Uh, Apart from that, you have explained that how to identify causality, how to do causality assessment and all that. But how
hmm,
to write that causality assessment, in which format or where we will write it, like after PT or after
hmm.
where company comment will be.
Okay, just a minute. We have shared that one paper with you guys. So you can look at that paper. However, that is for a vaccine. So just have a look at that as to how they have presented, or you can look for some online material. Let me see how they have presented here, because it should be easy to understand too. Don't look into the see. They have given the cumulative review. So consider it as interval review. Don't look at how they have presented. See how they have presented. Everybody has different ways. Say they have presented the risk on confounding factors as in table. If there are many cases, then you can prefer tabular format. Just a minute, I'll show you. It is quite descriptive. If you see, you will understand as to how we have discussed on that. Don't go for clinical trial. Just stick to
So there is a AstraZeneca comment. Can we look at that?
where
If
was
you
it?
go down, uh, go down.
Hmm. No, this is literature. Now they have gone to
Uh,
left. So this is
yeah,
literature.
yeah.
See,
This okay.
so they have these medical history concomitant investigation suggests that the event of CVST without thrombocytopenia unlikely could not be attributed to any disease or other drugs. See, they will analyze on that 6 to 7 parameters only, and whatever is the analysis, they will project it as company comment, or you can say AstraZeneca comment, Novartis comment, whatever you say. But it will be like this. But before giving this comment, you have to give a cumulative analysis so that you can means cumulative analysis. By cumulative analysis, I mean the cases which are um, fetched during the reporting interval. So that bucketing which you are doing, you will do that bucketing, and then you will provide the data based on that bucketing. Out of these many cases, these were there. Since this is a literature case, so they have given a see, like you can see causality used to perform causality assessment. Of the 500 case reported, there was one case report which met the causality for conditional or unclassified, 183 which met the causality for unaccessible. So they have used the WHO UMC criteria. So don't have to go into this. Whatever you have learned, just present based on that. Don't give the causality assessment here as unlikely, probable. That causality no need to provide, because you know that there are WHO UMC criteria. There is Naranjo analysis based on which we give this causality. So you don't have to use those terms. Just use this, that you have analyzed the cases on these 6 to 7 parameters, and this is the information that you got. Based on that, you can provide your company causality. Okay, leave it. We will not look at there. Let me look if I have something else. Let's see how they have presented. So here is hypersensitivity only. Yeah, I need a 37, no? See, this important potential risk. See how they have presented. See, during this reporting period, the MH received total cases they have given. They have given a bifurcation of serious, non-serious, medically confirmed and unconfirmed, with 104 events of potential immunogenicity. The case characteristics are summarized in table. They have summarized the case characteristics. So most frequently reported PTs are there. So they have taken top 10. So this is a different category, but you don't take into consideration this top 10 or top 10% or something like that. Just whatever is reported, you will, in your interview, you will say that whatever is reported, we will provide it. Now people used to give this percentage also. So how this percentage comes? So total 90 cases. So out of 90 cases, suppose it's 22. So 22 out of 90 into 100 is equal to 21.78%. So that's why how they have presented this PTs into percentage also. That how many percentage means what was the, because if you present in percent, it is quite evident to look at that data. Like this is in the data format. So whosoever will read, so he will look at what is the percentage, highest percent. So he saw that hypersensitivity is the highest PT reported. Then he might be interested. He can go down and see whatever is there. So they have provided PTs bifurcation here. They have provided seriousness bifurcation here. They have provided time to onset and equal to 18. Range they have given. Mean they have given. Median, that was I was talking about. Event outcome in 101 cases. What was the outcome? They have provided all the outcomes here. Then what is the action taken with drug? It is provided in 101 cases. It is provided that action taken was there, or total 101 cases. So no change. This how, see, can you see they have how they have bifurcated the data that you are bucketing there in the line listing? Is it clear from this table?
Yes, yes, sir.
See, gender, age, everything is, they are giving range, then giving mean, median, range. What is the median range? So this is how. Now, after that, they will present that their analysis. So review of the report suggested of lack of efficacy, drug did not identify any increase in frequency in cases in which sufficient information of causality evaluation was provided. Simple reporting rate of potential immunogenicity. They have provided reporting rate, means they will consider some standard, like they have to provide reporting rate in 1,000 patients. Here they have considered 1,000 patients. So they, whatever, like in 91 of the 12,314 patients, 12,341 patients who were exposed. So out of that, they have got 91 cases that we were discussing for frequency in the initial call. Okay. So in this is there. So they have presented in 1,000 cases in 1,000 patients, because frequency is usually in 1,000, 10,000, 100,000. Can you understand? Can you correlate here the incidence
Mhm.
rate or reporting rate, right?
Yeah, yeah. So according to RSI, it is normal. Not normal. Like whatever I report it is in RSI, there is no change in.
Right. So they have considered. So this data is coming from the sales exposure. That was the exposure during reporting interval. Okay. And this data is the how many hypersensitivity cases were there, as you have seen in the up table. Okay. So now in these many patients, if we have 91 cases, then in 1,000 patients, how many would have? So it's a mathematical calculation, simple mathematical. You will get 7.4 per 1,000. Okay. So if you go into the RSI and check what is the reporting rate in 1,000 patients, so it will show you as normal as per this. Okay. Then they have given a summary, means company comment, you can say. They have not mentioned company comment, but you can write company comment, and they have given a summary. See, immunogenicity did not identify new safety information regarding the potential risk of immunogenicity in OLI studies. No anti-lethal have been detected in the presence of. What was the focus of analysis? Important potential risk. They have provided their analysis here. So do you have idea as to how we present it? It's simple, nothing. The main work is into the line listing. When you are preparing your working copy of line listing, that is the main work, the main part of work. After that, you have the data handy with you. Just you have to present it here. And when you are working for a client, there is a set format. In that format, you have to put those data and you will have to present the section. Okay. Any doubt? People?
Yes, I have a doubt. Apart from the important risk, do we mention anything about the non-important risk in
No,
aggregate report?
no. In one session, I told you, you people don't have to say about non-important risk anything. You just say that we present only important identified, means important risk, important identified, important potential, and missing information. No need to mention about non-important.
Okay.
Any other question? People? Is the training so good that everyone is getting at one shot only?
Actually, everybody should note their doubts in paper or something.
The more you ask the doubt, the more it will be clear for everybody in this session. Because everybody would, I'm certainly sure that everybody would be having even a smaller doubt also. So you should ask that doubt. There is nothing silly because you people are learning this. Everyone is new to this concept, aggregate and signal. So it would be better if you ask the doubt and get it clarified. Instead of getting confused into the interviews, get confused here, clear your confusion and be confident. Chalo, then we will move forward to missing information. So see, in missing information, what we do differently, because it is a missing information, it is a knowledge gap. So certainly there won't be any information about this risk or missing information into your RSI. Your RSI would simply be stating that we have not studied this, or we have means there would be nothing much mentioned about this missing information in your RSI. Correct? Am I correct? Like for important identified, important potential, you are finding different things, different statements are there in RSI, but for missing information, there won't be any statement, right?
Right.
So
Yes.
now what should be our approach while analyzing the missing information? So see, in missing information, causality part, as we discussed for important potential, is it would be same. On the same lines, you will uh, bucketize the cases, try to find the causality, what is the data. Okay. Now, what is the difference here in missing information? In missing information, whatever cases you will get based on your search criteria. So first of all, you will distinguish those cases based on that criteria, like initial, follow-up. In follow-up, if something is mentioned about your missing information, then only include, otherwise exclude. Then whatever remaining cases are there, you will provide that how many were HCP, how many were this, that. That's no problem. Okay. But in missing information, you can keep that bifurcation if you want, for means it depends on client to client, but everybody does like that. They give the bifurcation after doing the second part. So suppose you got 100 cases, out of those 10 cases were follow-up, 90 were initial. Now all the follow-up, they didn't have any information about the missing information. So you have excluded those. So now you have remaining 90 cases. And that too, all are initial 90 cases. So in this 90 cases, you will first pivot the table bifurcating the unlisted and the listed events. The main point is this in missing information. Okay. First, you will bifurcate the cases in unlisted and listed category. By unlisted and listed, you understand?
Yes. Yes. In RSI, we check the labeling.
We check the labeling, or there is a column in the line listing which states about that event, whether it is listed or unlisted. Because in ICSR, you do listing, right?
Yes.
So from there itself, we get a column into the line listing, which will say that whether it is listed or unlisted. Let me check if it is here or not. Okay. So why it is not here? Because this listing was for signal detection. So you have to check the listing from RSI. That's why it's okay. But usually in aggregate reports, you will have a line listing in which there would be a column stating whether this event is listed or not listed. So you will pivot, you will put a pivot, differentiate how many unlisted and how many listed cases are there. So you will present a table the same way they are presenting the table. So you will present a table of unlisted events and a table of listed events. Okay. So first you will capture the section of unlisted. First you will start the section of unlisted because that is important. So now suppose if you are presenter, suppose there are 10 cases in which there are PTs that are unlisted. So you will go into your Excel, you will mark those 10 cases, and then you will try to bucketize those 10 cases based on the 6-7 parameters that we learned on important potential risk. And then you will present the data in same manner as you are presenting in important potential. The same thing. The only difference is first you have to bifurcate into unlisted and listed. And then when you have got all the data, you have bifurcated and you are presenting the data in report, and you will provide your causality based on the parameters that you have bifurcated, and your causality assessment will be provided on the same parameters as to what your company standpoint on these unlisted events. Okay. And then once it is presented, then you will go for listed events. You will present that these many were the listed events as per the below table. In that you will provide, and there is no need to provide a causality for the listed events because they are already listed. That is a known safety profile. So did you get the concept why we are bifurcating into unlisted and listed in missing information?
Oh, so why we are not doing that for potential and identified, listed and
See, when you are doing a potential risk, so that risk is there in your RSI, right? Or identified risk. So that risk is there in your RSI. So is it listed or unlisted?
okay, got it. Yeah, it is listed. So it will
Mm.
not be unlisted, but
Right. There might be certain events in potential risk. Like suppose if you have used a RSI means SMQ of hypersensitivity, in that hypersensitivity, the risk is listed. The risk is there in your RSI. There might be certain PTs which are unlisted, but you can give those PTs if you want. Means if your MR want, then you can give those PTs as unlisted. That these PTs are unlisted. However, the broader term as hypersensitivity is listed in the reaction. So ideally, when you are doing a risk, whether it is a potential risk or identified risk, so that is there in your risk. That is a known risk in your R. The only difference is for identified, you are trying to identify if there is any change in severity frequency. For a potential, you are trying to identify, establish the causal relationship. If causal is association is established, then you can upgrade it to identified risk. But in missing information, what happens? You don't have any idea about the safety profile for that, like is used in pregnancy. So if a pregnant woman is using it, you don't have a safety profile for that pregnant woman because you have not studied that drug in clinical trial. So in this case, you will look for unlisted and listed, and the unlisted PTs are most important for you because they are the emerging safety profile for pregnancy cases,
so
right?
it will be unlisted only, na, because it is not there in RSI.
Which one?
The PTs we are bifurcating. Sorry,
No,
the
no, no,
cases we
no.
are bifurcating.
No, no, no. You are confusing again. See, what happens? Suppose if it's a case, your missing information is used in pregnancy, right?
Yes.
So, use in pregnancy, there would be a SMQ of pregnancy and neonatal topics that you will use as a search criteria. Okay. Based on that search criteria, you will get many PTs. There are around 2,400 PTs in pregnancy and neonatal topics. Okay. So, when you have got those PTs and the cases from that, so it might happen that it could be having a PT of suppose QT prolongation. Suppose if it's just an example, it is having a PT of QT prolongation. Now you will go to your RSI and look whether QT prolongation is listed. It is not necessary that it will be listed, right? If
Yes,
there is
yes,
no risk of cardiac disorder, so it highly chances are there that QT prolongation is not listed in either section 4.3, 4.4, 4.8, or interaction overdose is different, or interaction section. There won't be QT prolongation listed. So now the QT prolongation in pregnant woman is a unlisted PT for you, right?
yes,
So you have to analyze that QT prolongation as to in pregnant women what happened, why this QT prolongation happened, because this is out of your RSI information. So you need to present the causality for that. Correct?
yes,
Sir, here I have a question. Like, if we consider this listing we have received for the section 16.3. Now,
Mhm.
how are we going to identify that these PTs I should be considering under the missing information?
Yeah. So see, when you have asked for data request, so you have given them search criteria. Okay.
Correct.
Like suppose this hypersensitivity is your important potential risk.
Mm-hmm.
So you have given them search criteria that this is my important potential risk. This is the search criteria. Please give me the listing. So they will give you a listing of hypersensitivity. So you will be focused on that listing from hypersensitivity perspective as important potential risk. Now, in the same manner, you will have asked them for missing information. Suppose use in pregnancy is my missing information, and my search criteria is broad SMQ of pregnancy and neonatal topics. So in the in the data request, you have given them that important missing information under this use in pregnancy. What is the search criteria? Broad SMQ of pregnancy and neonatal topics. So they will give you in the same manner. They will give you that this is a use in pregnancy line listing, this is a hypersensitivity line listing, this is a QT prolongation line listing, this is a cardiac disorder line listing, this is a use in breastfeeding, this is use in pediatrics. So whatever information you have requested in data request, they will give you in the same manner. So you don't have to means you don't have to analyze there which listing I have to use for which. They have given you the line listing, you have to use those line listings for that section only. Did you get my point?
Okay. Okay, yes, got it. So initially we have to give them we want this information that the way we discussed in the
Right,
risk session, how to
right,
identify the missing info. Got it. Good. Yeah.
right. So every section
Okay.
will have their individual line listing from where you have to analyze and present.
Okay.
Um, um, the listing which will be provided to us will have listedness column, right? So
Yes.
that listedness will be USPI or CCDS. How we will get to know that?
Yeah. So good question. Actually, what happens like if you are doing a global PBER, we discussed when we were discussing about RSI that if you are doing a global PBER, then we use by default CDS is there as an RSI, right? So when you will raise the data request, that time itself you will tell them that this is the RSI that has to be used, and there will be the listing, means listedness done as per that RSI in Argus. So they will put a CDS RSI because once you generate the line listing, there is an option to select the RSI. So if you have mentioned in your data request that CDS is the RSI used for this report, so they will provide you the listing as per CDS.
Okay, got
Okay.
it. Yeah, because there will be multiple RSIs
Right. Right.
for which the labeling will be done in ICS also. Yeah, thank you.
Correct. So for global, you always use CDS. If you are doing something about European region, so in that case, SMPC will be your RSI because Europe wants SMPC as an RSI. So in that case, you have to request them that give me the listing as per SMPC.
Sir, what is the difference between different RSI? Means, is it CCDS and other RSIs are different? And if different, then what means like what are the sections which have been different?
See, there is nothing you can say that difference between the RSI. Only difference is that Just CDS, what happens? CDS now, that is your company's core standpoint. Means as a company, suppose I am AstraZeneca and I am marketing COVID-19 vaccine in 19 countries or 20 countries, suppose. Okay.
Mm.
So for each country or region, I cannot give means everything I cannot give as per each region. So I should have a core standpoint that this is my company's core standpoint for this molecule, be it any risk, whatever risks are there. So what happens that CDS is prepared for such type of companies who are marketing the product in more than two or three countries. So they usually prefer to have a CDS. So CDS will have the company core standpoint. Okay, whatever safety information. Now, what will happen? Suppose if you go for European region, so they ask for SMPC. So there might be certain reactions that happen in European specific population. Like the drug is marketed in Europe, US, Canada, India, row countries, suppose Mexico. So, but the European ethnicity or the European people are more prone to certain risk based on the molecules. So, what will happen if they identify those risks for European region? Then they can add into SMPC. The European EMA will ask you to add that risk into SMPC. So suppose if you don't have a CDS, then you will have to go and change it into each and every RSI of all the regions. But since it is specific to European region or it is a risk specific to Europe, we will mention it in SMPC, but we will not change our CDS. So our CDS will work as RSI for everywhere. That is our company core point. But for Europe region, since RA has requested and that is specific to European population, so I have mentioned the risk into the SMPC. So that's why we have different RSIs based on the region, but a company core standpoint is into the CDS. So in CDS, in a nutshell, in CDS, you might have lesser risk in comparison to regional RSIs like EU SMPC or Canadian product monograph or USPI. They might have more risk, but CDS can have lesser risk. But it will never happen that CDS has more risk and SMPC has less risk.
So, sir, if they ask that which reference safety document you refer for all those things, so if we are saying that we are referring the RSI, okay, then there is a section like 4.3 or 4.4 sections are there for which we are saying for identification of risk and all. If they are asking that, do you use, have you used CCDS or all those things? So we can say like this, that means like same section is there in the CCDS or something different is there, or we
Same
can
section, same section, 4.3, 4.4,
okay,
4.8,
okay,
all sections
okay.
are same.
Similar मतलब no change in the section, only
No,
change in
no,
the risk and all thing.
no change in the section.
Okay, okay. Thank you.
Any other question, people? We are done with important identified, important potential, and missing information. So any questions till now?
Sir, in paper interviews means like aggregate, so they mostly focus on 15 or 16 section only, means like most of the interviewer are mostly focused on.
Mainly they are focused on 15, 16, but that we will discuss later on.
Acha.
Whatever safety sections are there, most of the interviewers are focused on safety sections.
Sir, one last question. For the missing information, you mentioned that we will be using the broad search criteria. So, is that correct? So, if they
Yes.
ask question about, okay, thanks.
Yes. Other than important identified, because that we have causality established and everything, 99% important identified, we use narrow SMQs. But other than those, for important potential also and for missing information, most of the time we use broad SMQs only
Okay.
because we don't want to miss on any of the PTs.
Hi, Amit.
Yeah, tell me.
Amit, for that important identified risk, we know that we have an established causality. So still we will write that company comments, right? So for example, here like a hypersensitivity we are considering as a risk, and these are the cases we have obtained. So all these are aligned with hypersensitivity only. Now for writing that comment, we know that there is an established causality. Like how we can bifurcate there in writing that one, because suppose TT also is there, and we have compounding factors also available, and other factors are also there. So based on that, at the end, how we will determine that it is not due to our drug or we have limited information, how we can do here.
Okay, so for important identified risk, if you ask, then you don't assess the causality there. What you do, you give the means the bifurcation, like how many, what was the reporter type, what is the report type, spontaneous, PMS, medically confirmed, non-medically confirmed, initial follow-up, serious, non-serious, then age demographics, sex demographics. After that, you give the PTs bifurcation, how many PTs were reported, that frequency. And while writing the company comment, you write the RSI statement. Like hypersensitivity is the important identifier. So what is mentioned in your RSI regarding that hypersensitivity, that statement you have to mention and nothing else. You don't do causality in important identified, right? Now, if you are asking for important potential, then I can tell you again.
For
Did you
important,
get my point?
I understood. Like for identified, there is no point for that causality thing and all. Just we are checking what are the parameters, right, as per that RSI. Understood. For important potential.
No. For identified parameters from RSI, but not that parameters, that 5 to 7 parameters, TTU and those things you don't have to check for important identified. You have to check only whether the severity is increased or frequency is getting increased. Just that thing for important identified. No need to check for TTU and all those things. That's why I told you this is the important identified only, or the identified risk that has a different viewpoint while we are analyzing. And for rest of the thing, whether it is important potential, whether missing, whether medication error, whether off-label use, you try to judge on all these 5 to 7 parameters and provide your causality. So now tell me, what is your exact question? What do you want to know?
No, my question is clear. Like I was just in a zone that okay, for important identified also that company causality is also required. But I forgot that point that no, it's already established. So we need to focus only on the seriousness and the frequency of that.
Correct.
Yes, got it. Other points are clear, Amit. Thank you.
Okay. Thank you.
Hello, Amit sir. I don't know if I missed something from this session, but I have a question regarding the missing information. As you told that we are considering the unlisted events. So for missing information, like the line listing we are requesting must be for specific type of condition, like if there is pregnancy related any it means pregnancy related events. So that means are we requesting line listing accordingly, or that means we have to, that means, analyze based on the provided line listing?
No, like suppose your missing information is used in pregnancy population, right? So at the time of KOM, you have got this missing information as used in pregnancy population, and with your MR, you have decided that we will use the search criteria of broad SMQ of pregnancy and neonatal topics, right? This is decided at the time of KOM. So when you are requesting for the line listing, you will ask them that this is the missing information. In missing information column, you will put use in pregnancy population, search criteria. Below that, you will put that broad SMQ of pregnancy and neonatal topics. Now, what the line listing team will do, they will go into the Argus. They will try to fetch all those cases with broad SMQ of pregnancy and neonatal topics. So it might happen that that case was also in the hypersensitivity reaction. That case was also into another risk of suppose cardiac disorder. That risk, that case was also. It might be that the cases overlap. But when they will give you the line listing of use in pregnancy with the broad SMQ search of pregnancy and neonatal topics, then whatever cases you are getting in that line listing, those cases you have to analyze for the unlisted and listed PTs and provide your causality based on that. Did you get my point?
Yes. I got it.
Okay.
And sir, SMQ is event specific, na? And line listing is case specific.
SMQ is risk specific, and line listing is for all the cases in that SMQ or the search criteria that you have.
Yeah, but the SMQ is for that specific risk or some
Right.
event, means like which we want to have more focus, means like.
Right. SMQ is risk specific, and then line listing is case specific.
So it is the only difference between line list. If someone asks what is the difference between SMQ and line listing,
Nobody will ask this because line listing, everybody understands that whatever search criteria you put,
Uh-huh.
you will get a line list. Line
Yeah.
listing is simply means that a series of cases,
Yes, sir.
means you listing of cases or series of cases into Excel. That is line
Mhm.
listing. Okay. Don't confuse with SMQ and line listing. SMQ is the search criteria that you are using.
Okay.
Okay. Any confusion means how this question comes, like line listing, so you have to always understand that this will be series of cases, line listing. And
Sir,
SM,
I got it, sir. Line listing is the bulk of the cases which been stored, means like which have processed in the database, and if you are requesting
right,
that during that whatever the cases has been processed, they present it into the Excel form.
right.
And SMQ is our search means like search criteria, means like what we want more specific from that line listing.
We use SMQs as a search criteria. It might happen that for certain risks you don't use SMQs, you use only combination of 10 or 11 PTs. So that is a search criteria. That is a part of search criteria, whether you are using PTs, whether you are using SMQs, whether you are using HLTs, whether you are using HLGTs. So those are part of search criteria. Depending on your risk nature, you decide those search criteria. Any other question, people?
Yeah, hi, sir.
Yeah.
So for the missing information, for example, my criteria is the elderly patient. So I will give the criteria like they pull all the cases with that particular drug with elderly as a patient, like 65 and more age. Okay, so we will receive the line listing of all the elderly cases, irrespective of events and all these things. Like drug and the patients only, right? This is the only two criteria I have.
Right. So what
So,
happens?
mm,
Yeah, complete your question first.
yeah. So, for example, I received the 10 cases. So from the 10 cases, we will analyze like how many serious, non-serious. And if it is serious cases, so we need to evaluate like if it is related or not related. Means we need to analyze the causality with the ARC suspect drug. And if it is related, if it is not related, then we can like say like there is no any new information for this missing information. And if it is related, then we need to summarize all these serious cases, right?
So, see, first of all, you have to correct your understanding a bit here. We don't analyze the cases based on serious and non-serious. For missing information, we analyze the cases based on listedness, whether it is unlisted or listed. First thing. Okay. Now, when you got the unlisted cases, so listed cases, so they are as per the RSI. That safety profile is as per RSI. You can mention that these are the listed cases. You give the bifurcation of those in a tabular format. Done. But for unlisted cases, you have to bucketize those cases based on these parameters that we discussed here. Can you see TTO, medical history, concomitant medication, DCHRN? And then you have to present those 10 cases based on this bucketizing as to what you found in these cases. First, you present those, and then you provide a company comment that based on this information that you got, are you able to get something substantial related to causality? If yes, then present that. If no, then write that what is the limitation due to which you are not able to assess the causality in these 10 cases. Did you get my point?
Yes, yeah, very good.
Okay. And the second thing I like to tell, like if it is an elderly patient case. So in elderly patient case, what will happen? You don't need to request additionally, okay? Because there is no search criteria of SMQ or something like that. There is simple search criteria that age above 65 years. So you will just put a filter of age above 65 years into your line listing of interval cases. For there would be a interval cases line listing requested, okay? So in that line listing only, if you put a filter of age above 65 years, you will get all the cases related to elderly. So no need to request additional elderly cases line listing.
Okay, right. Yes.
Okay, so in this way, you have to think like this. If there was SMQ, then you definitely need a line listing. But if there is a age criteria, in the same way, if it is pediatric case, so age less than 18 years, if you put a filter, you will get the pediatric cases. No need to request them for additional case line listing. Okay, so these are the things that you need to think on your own, because they might ask in interviews to confuse you. So do you request line listing for elderly cases? Do you request line listing for pediatric cases? Did you get my point?
Yes. And if we want to summarize the cases, so we need like fatal cases, we need to summarize, like serious.
Yeah. Fatal cases are always considered as priority. So we need to look at those fatal cases. And first, we look whether that fatal outcome happened due to the event which was caused due to drug, which was caused due to our drug. It will be available in narrative. If you can figure out, then it's fine. You can exclude that, saying that this fatal case was not related to the event which we are talking about, like hypersensitivity. So suppose fatal happened due to QT prolongation. It is mentioned in the narrative, not due to hypersensitivity. So you can exclude that case. Say the reason in the report that this case was excluded as the fatal outcome was associated with QT prolongation.
Yes. Right.
Got it? So exclusion inclusion criteria you have to always keep in mind. You have to present only the relevant cases in the sections.
Okay, Amit, so what is the significance of 16.3 section? Like how it is going to impact our RSI or something?
Yeah, so 16.3 is basically, you can't say that it is going to impact your RSI, because first of all, always remember that whatever you present in aggregate doesn't give a direct outcome. If something has to, means if some outcome has to be there, then there has to be a signal open and evaluated, and then based on that, some outcome is decided for RSI. First thing. Now, what is the significance of 16.3? So see, whatever risks are there. So from why we are writing PBER, we are monitoring those risks and we are trying to evaluate that there is no change in the risk benefit profile of the drug. So 16.3 sections. What is the topic of the section 16.3? New information regarding the risk, right? Signal and risk evaluation. So new information regarding important identified risk, new information regarding important potential risk, new information regarding missing information. So in the reporting period itself, what is the new information that you got that is not known to you at the time when the reporting period started for that? So that new information you have to present. So suppose you got the cases, initial cases into this reporting period. So what is the gist or what is the summary from those initial cases? Are these cases pointing towards some new information, or they are as per what we know for that? So for your clear cut understanding, I'll tell you that in 99% of the aggregate reports, there is nothing changing from what we are knowing at the start of the reporting period in 16.3. So that's why we present the data and say in the causality assessment that there is no change, or in the company comment or summary that there is no, when you have analyzed all those things at the end of the important potential risk, you will write that there is no emerging safety profile or there is no new safety information related to this risk that could impact the benefit risk profile of. So that is in 99% cases. If somebody asks you, did you find anything new? So say that, no, I haven't found till now. Everything is as per the RSI and whatever information we know till the start of the reporting period. Okay.
So we just have to present it, whatever new information is there. What exactly
Yeah.
it is going to do in on upcoming RSI or anything like that, we don't have to worry about that.
No, you don't have. Suppose if it is causing some impact, like suppose in 1% cases, if you are finding something new or different, so you will present in the aggregate all those cases in the company comment, and in the summary you will say that this is the new information that is being that is found, and the company has opened a signal which is under evaluation, and the summary or analysis will be presented once it is completed. So your work is done for aggregate. Now there is a signal team that will work on that new information. They will validate it. They will open an evaluation report for that. The evaluation will be done, and in evaluation, if it is confirmed, then there will be a SMT meeting, safety management team meeting, in which that information will be presented, in which there will be PV science team, there will be clinical science team, there will be regulatory team. All the members are there in that SMT. They will collectively decide that yes, this is the new information that is going. We need to update our RSI. Then they will recommend the action that we need to update our RSI. Then a recommendation of action will be initiated. RSI will be updated in the same manner. The next, when you will start writing the next paper, you will get the new RSI in which that risk will be there. So did you get how the life cycle follows for all this thing?
Yes, yes.
Based on aggregate, we don't do any changes. We have to open an evaluation report, detailed signal evaluation report. Based on that and SMT decision, we will see whether we have to change the RSI or include that information into RSI or what. So that is a different part. Anything else? Tell me, people, any question, because I don't think that I will cover next topic today. Let's ask your question. Otherwise, we will stop the recording and take your questions. Tell me any question related to the topic today, or maybe any topics that we covered previously. Anyone?
So is there so I forgot about the signal team. Is there a different signal team, or we will do the detection and all that?
No, ideally there is a different signal team. Aggregate team does it only the aggregate part.
Sir, like while preparing the section 15, which is for the signal, okay, so we can say that we get all the information from our signal team or some signal tracker, and we just see that which has been, what is the close signal, what are the during our reporting interval, or we
Sorry,
have
I
to
missed your question. Please repeat again.
like for signal for writing the signal section 15. Okay, so we can say that we get a signal report from our signal management team, or we can say that we used to analyze and we used to write those things, because what I remember in the section 15, that there we present a like in tabular form, like that what are the close signals, and which if it is being closed during our reporting interval, what are the source of it. So we can say that we get information and we just use to copy paste, or something more specific we have
No,
to.
that is a simple section. You can say that we have access to signal management tracker. Always
Okay.
remember there is a signal management tracker. In that, all this information will be there. That which event is opened, when it was closed, what was the trigger for that event, signal, what was the conclusion for that signal, was it refuted, validated, confirmed. Everything will be there in that signal management tracker. So you just have to put the date filter, and then you have to take all the information that is presented there in your reporting period and present the same table into section 15 and refer to the appendix 3 or 4, whatever is as per your format. So there will be appendix 3 also based on that table only. On that table, based on that table only, you will present the appendix 3 also from signal management tracker. It comes directly from signal management tracker. No need
Okay,
to.
we can say, and later on if they ask that what are the refuted, what do you mean by closed, and or then we can explain it, means like what.
When they ask, then they tell them. But always be clear about the terms. When you use refuted, when you use confirmed, when you use validated, when you use non-validated.
Okay.
Because validated, non-validated, you use after the validation step. The first validation step is done. In that, if it is validated, then it becomes validated signal. If non-validated, then non-validated. And when you do the signal evaluation report, after that, if you confirm it, then it become a confirmed signal. And if you refute, then it is called as refute signal. So use those terms appropriately.
Sir, signal confirmation is done by MAH or some like the FT or EMA does the final confirmation for the signal.
No, it is MAH responsibility first. If you have identified some signal through your system, signal evaluation system, like Empiric or something, then you are doing signal evaluation report. And then there is a team SMT, I told you, signal safety management team. So that team collectively decides whether whatever you have presented in evaluation report and confirming it. So is it confirmed or not? If it is confirmed, then you will go to SMT for confirmation. But if it is refuted, you can refute. And then as you are mentioning MAH responsibility, so if you have identified, it is your responsibility. MAH responsibility to confirm or reject the signal or refute the signal, right? But there are certain signals that come from RA, matlab regulatory authority. So regulatory authority, first they will ask you to evaluate the signal. And if you have evaluated and said that, no, I'm not finding any causality association with it, so I'm refuting it. Then RA might come back and say that this MAH means you are supposed Novartis, then they will say that AstraZeneca MAH has considered it as confirmed. They have updated their level in EU region. The SMPC is updated. Suppose it is EURA. So you also need to update your SMPC. So in that case, you will have to update your SMPC. So that is a regulatory authority imposition on you that you have to update your SMPC with this risk. So in that case, you will have to update your
And sir, for writing 16.2, that is the overview of the signal evaluation report. So we can means like we can copy paste from that. We can say that we get a report, and from there we used to copy paste for writing 16.2
Correct.
section.
Don't use copy paste info in that. Just say them that there is already a signal evaluation report that is prepared for that closed signal, from which we import information into our aggregate report. And also the same signal evaluation report is attached as appendix to our report.
Okay.
That signal evaluation report is attached as appendix also.
And sir, this report we get it from signal management, I mean the signal team.
Yes, signal team will give it.
Okay, that is not present in for signal. We can say that we get it from the signal. There is tracker, and from the tracker we used to extract the information for writing.
There is nothing hard and fast as to what you can say. You can say, suppose if there is something related to signal, so SMT tracker, if you don't want to say that you have access, you can say that we request SMT team, signal team to provide us the signal log for the current year. They will provide us, or we will ask them to provide us the ongoing and closed and open signal for this. They will give us from the SMT tracker. In the same manner, you can say that for 16.2, we request signal team to provide the DSR or the signal evaluation report, based on which we import the information into aggregate report and append that signal evaluation report as appendix to our report. Simple. If you don't want to indulge into that I have access to the SMT tracker or something like that. But usually what happens, whatever signal is there and you are a PV science person, so you have access to everything. Signal evaluation report also, you don't need to ask to anybody. There is a SharePoint repository from where you can take that signal. Because you are a PV science person from your domain itself is working on signal also. So we have access to everything.
Okay.
Sir, you mentioned that we receive some request from regulatories. So that information will go in the section 15, right?
So little bit you are confused. Suppose if some regulatory authority has asked you to evaluate certain things, suppose a signal or a monitoring issue. So if they have asked you to evaluate and you are evaluating it as a signal and it is still not closed, it is still under evaluation. So you will present under 15.1 as a tabular format, give an appendix to it, because it is not closed. So you can't give the evaluation. So you will not go to 16.2 first thing. Okay. Now, second criteria, if suppose RA team has asked to evaluate it as a signal, you have evaluated it as signal, it is closed, but you are not considering it as a means the causality is not getting confirmed, but you are also suspecting it. So now you are not able to make it a risk. Signal evaluation closed, you are not able to make it a risk, but you are also susceptible that causality might be related. So in this case, you will put under safety monitoring issues, right? You will
Okay.
put this signal onto safety monitoring issues. So when it becomes safety monitoring issues, so it will be presented under section 15.2 because you are
Okay, got
monitoring
it.
it as a safety issue.
Okay, got it.
Okay.
Yes, yes.
And if suppose RA has directly asked you to monitor, no need to open a signal and everything, then also it will be presented under section 15.2 only. Whatever
Okay.
regulatory authority topics you are monitoring, that will be presented into section 15.2. Whatever signals you have closed, that summary will go into 16.2. Whatever risk information is there, that will go under 16.1 and 16.3. Whatever signal information is there, that will go under section 15.1 and the appendix to it. Am I clear with all the concepts?
Yes, sir.
Yes.
In nutshell, we can say that signal information goes into the section 15 and 16.2.
Right.
And
16.2 only if closed.
if signal is closed during your reporting interval,
Hmm.
that over then from evaluation, and risk is 16.1, 16.3, 16.4. Okay.
16.4 is characterization. That is a different, totally different from analysis. We will
Okay.
cover that. Don't worry. And it is a, you can say close to heart for every interviewer.
Okay.
Amit, what if they ask for signal team signal experience? What
So
will you?
you can say now you are doing detection and validation. Many companies, see, I told you that aggregate and signal team is different. It is the innovators. I mean, most of the companies do like that. But ideally what happens, like if you see the structure for AstraZeneca, if you see the structure for GSK, then what they do, like for AstraZeneca, I'll talk about, one of my friend is working there. So what happens there, that they will give the molecule to them. So in that molecule, whatever safety issues is related to that molecule, you only have to handle. So whether it is aggregate, whether it is signal, whether it is RMP, whether it is health authority query, everything has to be dealt by that person only. So you can always say that you are working on signal detection and validation part only because you have just started, and also working on PBERS. Simple.
That
So
all,
if they ask about this SMT tracker and all this, we can say we are only working for the detection and validation.
Detection and validation, you have the access to that, and always remember that since after this, okay, we are done with the topics, then we can discuss all these things. Any topic related question? No, right?
No, sir.
Okay, then just a minute.